So again, some of this is going to be for the video. So, so I'm Dr. Gregg Kokame, Chief of Ophthalmology, and today we're going to give you your only experience in ophthalmology at the John A. Burns School of Medicine, and it's really great to be able to address you as second-year medical students and give you some exposure. So this is an exciting introduction to ophthalmology today. The sense of sight is so important to patients, and you'd be surprised how important it is. When Johns Hopkins looked at this, the worst ailment that could happen to them in patients was blindness. That was the number one. It surpasses loss of limb, loss of memory, loss of hearing, loss of speech, and even having AIDS. So one thing I wanted to mention, I think people that have not been exposed to ophthalmology don't realize that there are so many subspecialties. And in order to do a subspecialty, you have to finish a residency first, and then go into 1 or 2 years of subspecialty training. And we're going to have a speaker in every area of subspecialty today. Comprehensive ophthalmology is like our family practice: cornea, external disease and refractive surgery, glaucoma, neuro-ophthalmology, pediatric ophthalmology, retina and vitreoretinal disease, and oculoplastic and reconstructive surgery. So comprehensive ophthalmology, again, that's like our family practice. You can treat the whole family at different ages, diagnosis and treatment of all eye diseases, cataract surgery, prescription of contact lenses and glasses, and of course, diagnosis of severe retinal diseases and referral to subspecialists. So one specialty, cornea, external disease and refractive surgery, take care of eye infections, corneal inflammation, scarring, and corneal ulcers. They do LASIK and refractive surgery and corneal transplantation. This is not a complete list, but just wanted to give you guys some of the things that they're able to do. Glaucoma, there's many different types of glaucoma, which is high pressure or pressure problems that result in progressive optic nerve damage. And it's not always related to high pressure, like many people think, but it can also happen even with normal pressure. Medical therapy, there's a very extensive array of topical eye drops and systemic drugs that are available. Laser therapy and surgical procedures to reduce intraocular pressure. Neuro-ophthalmology involves optic nerve disorders, orbital tumors and disorders, brain disorders affecting vision, like pituitary tumors, occipital lobe strokes, unexplained vision loss, double vision, and eye movement disorders. And pediatric ophthalmology involves treating the pediatric population. A big thing is amblyopia, where one eye is called a lazy eye, strabismus and misalignment of the eyes, pediatric vision loss screening and evaluation. When the babies are born very, very early, they get this retinopathy of prematurity due to undevelopment of the peripheral retina. Tumors and retinoblastoma, genetic disorders, and also eyeglass treatment for children and prisms for motility disorders. So another one is retina and vitreoretinal diseases. This is the back of the eye. So cornea is the front of the eye. This is the back of the eye. So this is related to things. The big three are retinal tear, retinal detachment, diabetic retinopathy, and retinal vascular disease, and macular degeneration. Diabetic retinopathy is so common here in Hawaii, and it increases in risk the longer the patients have diabetes, and also with poor control. Macular degeneration is the most common cause of vision loss. So it's very important in Hawaii and also in the rest of the US. And we also see genetic disorders, retinitis pigmentosa, inflammation, things like cat scratch disease can cause significant eye findings, toxoplasmosis, toxocara, syphilis, and age-related viral infections. Surgical repair involves inside the eye and outside of the eye surgery. And Dr. Atebara will be showing that to us later. Oculoplastic and reconstructive surgery, sometimes it requires removal of the eyes and blind eyes that are painful. Skin and eyelid cancers, eyelid abnormalities, tear duct problems, and orbital reconstruction. So a very extensive area as well. And an important specialty is uveitis. So uveitis is inflammation inside the eye, but there are many different causes. Of course, the differential diagnosis includes infectious, inflammatory, and tumors such as lymphoma. And it can be associated with systemic diseases such as lupus, and steroids and treatment with steroids and antimetabolites may be important. So just quickly, I wanted to go over the basic points of the eye before we get into subspecialties. The eye really is like a camera. So the pupil allows light to enter, just like the diaphragm of a camera. And the iris determines how much light is let into the eye. The cornea and the lens, the front parts of the eye, all it does is focus. So that does the focusing. But the picture that is taken is done by the retina. Those are the photoreceptors. And it sends the picture from the optic nerve to the brain. In the center of the eye is the vitreous. It's a gel inside the center of the eye. This is what causes floaters, which many of your patients will always talk about. If there's any sudden increase in flashes and floaters, the concern is for retinal tear, retinal detachment, but regular floaters that come and go is actually very normal. So the retina is made up of many, many different layers, and it connects to 1.2 million axons to the brain. So that's what actually allows us to have vision, and the brain actually then processes all that information. The peripheral retina gives us our peripheral vision, night vision, and the central macula gives us our excellent vision, our ability to recognize people, our ability to read. I'm jumping ahead because we usually have a talk about research at the very end, but we wanted to include uveitis this year. So I just wanted to touch bases on research in ophthalmology, which you may not be aware of. We were the first human treatment using gene therapy in Hawaii, and it involved treatment of macular degeneration. There's an adeno-associated viral vector that transduces the DNA material into the cell nuclei, and then it produces mRNA, which produces a protein. So this protein, I think everybody's aware of VEGF, vascular endothelial growth factor. Well, this protein is an anti-VEGF, so it decreases the risk of leaking and bleeding. And gene therapy, the big thing about this is it may allow the eye to produce its own medicine. So instead of injections every 6 weeks or every month or every 2 months, it may be a one and done thing. So if we can put the gene vector into the eye and get continuous medicine production, then we don't have to do more treatments, or at least decrease the number of treatments. So just to give you an idea of the kind of research that we're doing. So we're going to have a number of discussions, didactic lectures by our faculty. PBL is going to be happening after this, 15 minutes each, 6 rooms. We are going to start right after we finish this lecture, so there's no break in between. And the clinical skills program will be with preceptors in the office. I think Risa has organized this for you. It'll be this Friday and next Monday. So again, these are all the different speakers that we'll be having today. I'd like to introduce as the next speaker, Dr. Bill Wong, comprehensive ophthalmologist, and he'll be speaking about the general part of ophthalmology treatment.
All right, good afternoon. I'm Dr. Wong, William Wong. I'm a comprehensive ophthalmologist, and I pretty much specialize in cataract and refractive surgery. So I wanted to kind of give you an overview of what we do for comprehensive ophthalmology. So the eye care team is made up of the 3 O's. So you have your opticians, those are the guys who make your glasses and contact lenses. Then you have optometrists, who are doctors, but they basically do primary eye care. They can diagnose diseases and initiate initial treatment, but they primarily do prescription of glasses and contact lenses. And then of course the ophthalmologist, which is us. We have medical degrees, and we specialize in the medical and surgical care of the eye. So it's easy to remember, the shorter the word, the less they do. Here are some of the subspecialties in ophthalmology that Dr. Kokame already went over. So what do you guys need to know as the primary care physician? So about 2 to 3% of your office visits are going to be eye-related. So you need to know how to recognize certain diseases and when to refer for urgent ophthalmic care. You should be able to recognize conditions that can lead to vision loss and other systemic complications. Also how to recognize things like cataracts, simple refractive error, and strabismus in your office. So anatomy of the eye, basically starting from the outside in, you have your obvious eyebrow, eyelids, eyelashes. Then you have the white part of the eye, which is covered by the conjunctiva, which is the mucous membrane skin covering the sclera, which is the white part of the eye. It's like the wall of the eye. Then you have your iris, the colored part, and the pupil, which is in the middle. That allows the light to pass through. Going from the outside in, the light will go through the cornea, the anterior chamber, the pupil, the lens, which focuses the light onto the back of the eye, which is the retina. That's what translates the light impulses into electrical impulses and sends it to the brain through the optic nerve right here. Your central ophthalmic artery and vein pass through the ophthalmic nerve and supply the whole eye to keep it alive. So why do we recommend annual eye exams? So you all get your teeth looked at and cleaned maybe once or twice a year. So eyes are just as important, and a lot of people think maybe more so. So to detect ocular diseases, dysfunctions, or other ophthalmic signs of diseases, it's important to have your eyes checked annually because we can preserve visual function, or in the case of systemic diseases, prevent further complications and illness like diabetes and hypertension. So vision is very critical to daily function, so the public health impact of eye disease is quite substantial. Also, the aging population is getting larger and many of them are still driving, so I want them to be able to see well if they're on the road. The comprehensive eye exam starts out pretty much with the same things that you would do in your clinic: chief complaint, HPI, check for symptoms and past history, systemic history and medications, family history, social history, and review of systems. This is a very obviously infected eyeball. Then we proceed to the visual acuity exam. This is a Snellen chart. This is what you would put in your office on the wall, and you would stand back, have the patient stand back about 20 feet, and be able to read this chart best with their glasses or contact lenses. You want to be able to see what their best potential is, and you would test one eye at a time. If you don't have their glasses or contact lenses, then you could try with the little pinhole. And then you would record the acuity in Snellen vision, which is 20/20, considered normal, all the way up to 2200, which is the big E. In our office, we would then refract the patient to find out what exactly their prescription error is. So when you come to our offices for your clinical, we'll teach you how to do these things: the visual fields by confrontation, the external exam. You want to look at the eyelid, its position, eyelashes, the eyeball itself, skin around the eye, look for inflammation, rash, redness. And then, of course, you learn how to check pupillary function. The size is important, how fast it reacts to light. And there's also a thing called an afferent pupillary defect, where there is a difference in the pupil size, and it reacts differently to light. And ocular motility, which obviously this guy has a problem in this eye. So you want to see if the motions are full and together. We will do intraocular pressure using a tonometer with blue light and a yellow dye. You can also use a tonal pen, which is a digital instrument, to check the pressure of the eyeball. Or in your office, you would be able to use your fingers and gently palpate the eyeballs and see if there's symmetry or asymmetry between the two eyes. If there's a suspicion for a globe rupture or an infection that could potentially rupture the eye, you don't want to go pushing on it. Okay, we have a machine, it's called the slit lamp. It's a big ass microscope, and we can take a look at the different parts of the eye under high magnification. So we look at all the different parts of the eye, and we'll be able to tell things like cataract here, different types of cataracts, intraocular lenses. We'll also be able to look for corneal abrasions. With the same blue light in the dye, you'll be able to see a big abrasion on the eye like this, or an ulcer, scratches, or little foreign bodies. Little tiny specks on the eye feel like big rocks. Here in Hawaii, we have this thing called surfer eye. The technical term is a pterygium with a P. That's what this is. So we can inspect that. This is a cataract over here. There's a really bad cataract over here. So slit lamp can also give us some guidance as to infection. So corneal ulcers generally would be either bacterial, which is a lot of pus, herpes simplex, which has a characteristic dendritiform look on the surface of the eye, and this fuzzy, cloudy appearance could be fungal. Then we dilate the pupil and look at the retina. So obviously we have a normal retina here, an abnormal retina here. So this on the right side is a pizza-looking thing. That's your central retinal vein occlusion. On the other side, the retina looks white with a little cherry red spot in the middle. That's a central retinal artery occlusion. These are both very concerning diseases of the eye. You want to look at the optic nerve. This is what a normal optic nerve should look like. And when you come to the clinic, we'll be able to teach you how to use a direct ophthalmoscope, and hopefully you'll be able to see this, or at least parts of this. Papilledema, you may have heard, it's swelling of the optic nerve, and this is what it looks like. There's different stages, 1 through 5. This is really obvious. It's like a zit ready to pop. On the other side of the spectrum, we have a pale optic nerve, or a glaucomatous nerve. So this is what's normal with the cup. As glaucoma progresses, the cup gets larger until it's fully cupped out and there's hardly any nerve left over here. The nerve will also appear pale and white instead of healthy and yellow. So from your standpoint, we want to be able to determine whether an eye condition is, no risk factors, or if there's something moderately at risk, or something super urgent like this ruptured globe, where there's intraocular content sitting on the eyelid. That's obviously something that needs attention right away. We deal with trauma. So here is a patient of mine who was out kayaking, fishing, and he caught his eyeball with his hook, and he took a selfie and paddled himself in and straight to the emergency room. So we were able to remove that and fix his eye, and he actually can still see pretty well. Blunt trauma will often result in what's called a floor fracture. Here on the left side, you have a small one where the contents of the orbit are protruding into the maxillary sinus a little bit. And here on the right side, you've got a big, complete floor fracture. So these are things that we pick up on imaging. You want to look for herniation or entrapment of the intraocular contents and muscles. So from your standpoint as a primary care physician, you want to kind of look out for things that require urgent referral, simple refractive error, corneal ulcers, infections, diabetic retinopathy or hypertensive retinopathy, and of course cataracts, which are my specialty, easy to fix, and patients are very, very happy afterwards. All right, so next up will be Jeff Wong. He's our cornea specialist.
So I'm Jeff Wong. I'm a comprehensive ophthalmologist as well as a cornea specialist. I also work with my wife at Honolulu Eye Clinic. She's Dr. Rupa Wong. She'll be speaking to you later about pediatric ophthalmology. So what is the cornea and why should we care? The cornea is the clear outermost layer of the eye. It's the window to the eye. It has to be clear, smooth, and ideally round to see well. Together with the sclera, it protects the eye from injury and infection, and it's essential for good vision, responsible for 2/3 of the refracting power of the eye, which makes it a great place to do refractive surgery like LASIK. So here are the layers of the eye. You have about 5 layers: epithelium, Bowman's, stroma, descemes, and endothelium. And as you can see, it's avascular. There's no blood vessels like the rest of our tissue. So we get oxygen to the eye through the air. And this is a model I show all my patients because it's sometimes hard to conceptualize what parts are what, but I find this is helpful. So we're going to go over a few common corneal diseases: pterygium, dry eyes, corneal ulcer, HSV, trauma, and keratoconus. So like Bill mentioned, pterygium is the surfer's eye. And it's so common here in Hawaii because we're so close to the equator. We get so much UV light. It's a fibrovascular growth from the sun causing degeneration of the conjunctiva, and usually starting in the inner corner, although it can also occur in the outer corner. The conjunctiva starts to creep onto the cornea. And this top picture, you'll see just a little bit onto the cornea, but it can also like press onto the cornea, distorting vision. It causes redness and irritation. Obviously, the bottom one is severe. Most patients would never let it get this bad, but this is covering the visual axis, blurring the vision. So if it's small, we just tend to observe it, usually treated with artificial tears, counsel the patient about wearing sunglasses, hat, avoiding the peak hours, maybe surfing in the early morning or late afternoon. The treatment is surgical excision with a conjunctival autograft, especially if it's getting too close to the center of your vision. So here's a nice before and after. On the left, you'll see that pterygium getting closer to the center of the vision. And the post-op is really nice where you can barely see that there was a pterygium even there in the first place. So dry eye disease is very common, affects about 16 million Americans. It's characterized by a loss of homeostasis of the tear film, causing redness, stinging, blurring, and burning. And we use this dye, fluorescein dye that Bill talked about. We put it on the eye, shine a cobalt blue filter, and you can see abnormal epithelium fluoresce. So all these little bumps, these little pinpoint dots, are irritation from severe dry eye. So risk factors include age, gender, certain diseases like diabetes, Parkinson's, Sjogren's, and contact lens wear. Some medications like antihistamines, antidepressants can cause worsening dry eye, as well as ophthalmic surgery like LASIK, and of course dry and windy environments. So how do we treat this? We use artificial tears, of course. Medications, there are a bunch that are topical eye drops. We even have a nasal spray that can help with dry eye. We also want to control the inflammation of the eyelids called blepharitis using warm compresses, sometimes oral doxycycline. So just to mention this, you may have heard there have been some terrible reports back in February about generic artificial tear. It caused 4 deaths, 14 patients to lose vision, 4 people had to have their eye removed. So this was from a drug-resistant Pseudomonas aeruginosa in a factory in India with poor sterility. So, I never thought artificial tears could harm anybody's vision, but I think we have to think about what we're putting on our eyes. They recalled some in this October, but I just tell my patients, try to stick to the name brand drops, which I trust more. Bacterial keratitis is a corneal ulcer and can cause pain, redness, photophobia, blurry vision, and discharge. The biggest risk factor is probably contact lens wear. And if you're a contact lens wearer, please do not sleep in your contacts. It increases the risk of infection by 8 times. And we see the gamut. We see some patients, they put the contacts in their mouth, when they're dry, and then they put it back on their eye. They sleep in their contacts, so don't do that. Bacteria, the most common are Pseudomonas, Staph, and Strep, and we treat these with topical antibiotics. If you don't get this under control, it can lead to this. This is a contact lens-related Pseudomonas keratitis with a lot of inflammation on the left. It finally healed with topical therapy, but left a big corneal scar. So this needed a corneal transplant for this patient to see better. Using that fluorescein dye, you can see other things. Sometimes people get HSV keratitis caused by HSV1, and you'll see that characteristic branching epithelial irregularity. And if you don't get this under control, these can lead to scarring and blurry vision. So we debride these just with a cotton tip and use oral and topical antivirals. Corneal abrasions, you'll see plenty of these. Again, fluorescein is your friend. They usually have it in the ER, and sometimes it comes on strips or in an eyedropper. And you put it on the eye, you can see exactly where the eye was scratched. We usually cover with antibiotics to prevent infection, sometimes patching with ointment, and sometimes putting a contact lens to give the patient comfort so that the eyelid is not rubbing on the wound. Corneal laceration with like a sharp implement can cause a puka in the eye. And of course, you should look at the pupil. It's no longer round. So if you're ever in the ER, you're worried about a ruptured globe, look at the pupil. Sometimes it points to the area where there's a leak. The fluid is coming out and it's kind of pulling the iris with it. And with that fluorescein again, you can actually see leakage of the fluid from the eye. Here's a repaired corneal laceration. And lastly, we have corneal dystrophy, keratoconus. It's the most common corneal dystrophy. Affects about 1 in 2,000, mostly teens to 20s. And of course, it causes blurred vision. You need a nice round cornea to see well. So mild cases can be treated with contact lenses. We tell them don't rub your eye because this cornea is a little more fragile. And we now have UV collagen cross-linking to stiffen the cornea and stabilize it, and corneal transplantation, which is basically like a cookie cutter. We're punching out the diseased cornea in A, discarding that, taking a donor cornea and just suturing it into place. And lastly, remember that LASIK is corneal surgery. What we're doing is making a flap using a blade or laser, putting the flap open, using another type of laser to reshape the cornea, and putting the flap back. We also have PRK, which is the predecessor, which is not creating a flap, but just scraping the top layer, reshaping. And that is it. Thank you.
Okay, all right. Hi everyone. So Oculoplastics is, I'm Bradford Lee. Oculoplastics is the intersection of ophthalmology and plastic surgery of the face. So I know in med school we always like to look at cranial nerves. So around the eye socket you have cranial nerve V1 and V2 coming out above and below the orbit. Cranial nerve 2, the optic nerve, comes out of the optic canal at the back of the orbit. And then 3, 4, and 6 come through the superior orbital fissure here. And these innervate and spread out to give innervation to the rectus muscles. It's also important to think what are the neighboring areas of the orbit. So you have the frontal sinus, the ethmoid sinus, sphenoid, maxillary sinuses. These are relevant because there are certain types of trauma, infections, and tumors that can start in the sinuses and invade the orbit as well. So let's talk a little bit about orbital fractures. If you're in an ER type setting, this is a fairly common complaint. Anyone who gets hit in the eye can have a fracture of the floor of the eye socket. We call this a blowout fracture. And in children and teenagers, there's a particularly dangerous type of fracture called a trapdoor fracture. And here you can actually see, oh, you can't see my cursor here. You can actually see the inferior rectus muscle is being tightly pinched through a minimally displaced fracture of the floor. And so when this patient is looking upwards, his left eye is tethered and cannot go up. And this can be an emergency. These patients can get what's called an ocular cardiac reflex, where their heart rate can almost completely stop. And this needs to be taken to the OR and fixed right away. Orbital tumors, you can have benign as well as malignant tumors. You can have things like a cavernous hemangioma, which is a vascular tumor, which can compress the optic nerve and cause gradual permanent vision loss. You can have rapidly progressive malignancies in kids, the most common being rhabdomyosarcoma. And then lymphoma is actually fairly common in the orbit, and is typically B-cell lymphoma, and it's highly treatable with orbital radiation therapy or Rituxan. In children, you can get this vascular tumor of the eyelid, which in bad cases can cause amblyopia. It can cause deprivation amblyopia because a kid can't see or gets astigmatism, and these can be treated with beta blockers or surgery. And then you can also get metastases. Sometimes, the presenting sign of a breast cancer could be an orbital metastasis with bulging of the eye. So breast, prostate, and lung are the most common. You can also get a whole bunch of infections. An orbital cellulitis typically starts with a bacterial sinusitis from the sinuses, and then can sometimes form an abscess. These patients are sick, they need to be hospitalized, started on IV antibiotics, get ENT involved. Sometimes they need to have an abscess drained. And then during the pandemic, this actually became a more common thing. It's called mucormycosis, and these can be very, very aggressive fungal infections that typically affect patients in diabetic ketoacidosis or immunosuppressed patients, organ transplant patients or cancer chemo patients. Patients can die from this within days if not treated properly. It spreads to the brain and they die of brain fungal infections. So they need IV antifungals. Thyroid eye disease is also something very commonly that you'll see in primary care practices. Every year there's about 1 million new cases of Graves' disease in the US, and about 50% of these patients at some point in their life will get some eye involvement. So obviously it can be very disfiguring, the eyes can bulge, you can get bad double vision, lid retraction, and a lot of psychosocial problems, as a result of this. It's important to note that radioactive iodine and smoking are very bad for thyroid eye disease, make it much more common and much more severe, so make sure you mention that to patients. Here on the bottom, you see a normal orbits, CT orbits, and here you can see how enlarged the extraocular muscles can be, and at the back of the orbit, you can get compression of the optic nerve, and again, permanent vision loss in bad situations, so that's why we try to treat them early. In terms of thyroid eye disease is an autoimmune disease just like Graves', and typically when they're having active inflammation, we want to treat them with optimizing their endocrine levels, smoking cessation. Previously we had steroids and radiation, but now there's a first FDA approved biological. It's the insulin-like growth factor 1 receptor inhibitor, and this is called Tepezza or teprotumumab. This is a patient who had Tepezza treatment with no surgery or anything, and there's significant reduction in proptosis. And then in the quiescent phase, once things are stable, then we can think about rehabilitative surgery to get the eyes back into the eye socket, straighten the eyes for double vision, and fix up the eyelids so that they look like their normal selves again. Orbital decompression is one of my favorite and most challenging surgeries to do. These are the bones of the eye socket, and we're basically drilling down the bone here and taking down the walls of the orbit to allow expansion of that enlarged orbital tissue into the sinuses. And you can get results something like this, where you take a patient who has bulging eyes, pressure behind the eyes, dry eyes, and then get the eyes back into their socket, make them look normal again. This is another patient who, before her thyroid eye disease, this is her after being disfigured by this condition, and then after orbital decompression surgery, lid surgery, even some cosmetic surgery, we're able to get her to a much more normal looking appearance. In terms of eyelid anatomy, there's a lot of different structures, but all of you think about ptosis and know that the two muscles that lift the upper lid are the levator muscle and the Mueller's muscle. It's also important in Hawaii to recognize that there's a lot of differences between Caucasian and Asian eyelids. The anatomy is very different. Asians have what's called an epicanthal fold. Half of East Asians have no eyelid crease versus half do. And there's several various other anatomical differences, but some of the common Asian eyelid surgeries are double eyelid surgery to form a crease in the eyelid and make the eyes look a little bit bigger. In the bottom, this patient had a low crease, wanted her crease a little bit more prominent. So these are typically cosmetic type patients. This is a patient with eyelid ptosis that's actually blocking his vision, and these patients have difficulty seeing above and in their peripheral vision. This is a ptosis repair to open the eyes up. As we age in ophthalmology, we see lots of geriatric patients, and you can get lots of extra skin on the upper lids, drooping of the brows that block the peripheral vision. And this is after removing that extra skin, lifting the brows. He also wanted the bags gone. So those are all things that we do in oculoplastics. There's a whole bunch of other weird and rare types of ptosis, including myasthenia, cranial nerve palsies. You should know about this, but we don't have time to talk about all of it today. The lower lid can have different types of malpositions. The lids can flip outwards or they can flip inwards. Both cause drying out or scratching and irritation of the ocular surface and can be extremely uncomfortable for patients, so we can fix these lid malpositions. As oculoplastic surgeons, we are also the dermatologists of the periocular area, and we treat all of these benign and malignant lesions. Very commonly, you'll see patients who develop styes or hordeolums. These are blocked oil glands in the eyelid, which can get infected and become painful. And then, of course, we see lots of skin cancers on the skin of the eyelid or even the lid margin. Basal cell squamous are the most common, but sebaceous carcinoma, because of the oil glands, is very concerning. It can be deadly as well. So depending on how big the defect is, we work in conjunction with Mohs surgeons, who are dermatologists who specialize in cutting out the cancers with minimal tissue loss. And these are examples of things, like after a basal cell is removed, the Mohs surgeon sends it to myself. We rotates the tissues around. You can even treat it with some laser to make that scar disappear. This is another advanced basal cell, and I did a skin graft from his other lid to reconstruct that eyelid. And then finally, we also take care of the lacrimal system. So we have a gland called the lacrimal gland, which is like a rain cloud that produces tears. And then you also have the drainage system where the tears drain through these holes called the puncta down into the nasolacrimal duct. And so you can have, anywhere you have blockage along the drainage system can cause dripping and tearing and sometimes infections of the tear system. Many newborn babies it's fairly common to have congenital nasolacrimal duct obstruction, and they can have tearing that oftentimes will resolve on its own. But in adults, if you develop a blockage of the system, you can sometimes get infections or tearing, and then we think typically about doing tear duct surgery called a dacrocystorhinostomy, which is a fistula so that the tears can drain into the nose again. That's about it. Thank you very much.
Well, good afternoon. I'm Troy Tanji. We'll be talking next 10 minutes about glaucoma. I graduated from JABSOM when we were still back in Manoa. Went to the LSU Eye Center for residency, then fellowship at the Doheny Eye Institute. Well, glaucoma is a neuropathy of the optic nerve. It's the leading cause of blindness worldwide. 80 million people we think have it, and half still don't know they have it, and over 10 million blind. So it's a big problem worldwide. Major risk factors include your race, kind of darker you are, higher risk, advancing age, and higher intraocular pressure. Intraocular pressure is the only modifiable risk factor for glaucoma. And all the action in glaucoma happens right here where the optic nerve connects to the eye. And with your ophthalmoscope, we're actually able to see the optic nerve like Dr. Wong mentioned earlier. Glaucoma is a progressive disease. This normal appearing optic nerve can develop a disc hemorrhage here, followed by loss of that nerve tissue, kind of like eating a donut but from the inside. Right here is all missing. Function follows anatomy. As nerve tissue is lost, there's a constriction of the visual field. This is a printout. Black means patient doesn't see it. Less nerve tissue, less vision. And this is supposed to be a video showing how early glaucoma, there's splotchy vision in the middle and also narrowing. And if you look side by side, if this is normal, this is somebody which would be considered has moderate glaucoma. Driving a car is really dangerous, and we know these patients have a lot more car accidents. So once we figure out patient has glaucoma, we turn our attention to intraocular pressure. Intraocular pressure is a balance between the aqueous formed by ciliary body and outflow through the trabecular meshwork, which returns it to the venous circulation. Two major types of glaucoma are open-angle glaucoma, which makes up 90% of our glaucoma. On our exam, we don't really see any blockage to the outflow, and much less common angle closure glaucoma, where we see iris blocking the drain. Using a laser, we can make a hole through our iris, which is helpful in that situation. The ciliary body, for all eyes, pretty much make the same amount of aqueous, so it's outflow or drainage, which is the problem. In the United States, how do we treat glaucoma? It's considered a medical problem initially. And we use a lot of medications. I'll go over the first five, the top 5 medications we use, basically eye drops. And one trick in our office is older patients get glaucoma. They don't know what medicines they're on. We go by the color of the cap. So this teal cap are prostaglandin agents. It's the #1 medication in the world used for glaucoma. It helps increase outflow. Doesn't really have systemic side effects, but we try not to use it when a patient is pregnant because it can theoretically induce labor. The gold standard are beta blockers. They usually have a yellow, sometimes a blue cap. And just like systemic beta blockers, you have to be careful using patients with asthma and also with a slow heart. But patients who are on this timolol topically might have bradycardia, and that a lot of times means they need a pacemaker. Beta blockers reduce the amount of aqueous made. Second line treatment are alpha-2 agonists. A purple cap reduces the amount of aqueous. It's related to clonidine, so it has similar side effects such as sleepiness, and contraindicated in infants due to apnea. One systemic medicine that you might see a glaucoma patient on is acetazolamide, which is a carbonic anhydrase inhibitor. Has a lot of side effects, so we only can use it short term because this enzyme is in the eye as well as the kidneys. It's a diuretic, also messes up your acid base balance and causes a lot of bad side effects. This eye drop was developed, no systemic side effects of the pills, but these are a concern because it is a sulfa type medicine. And our newest medicine is Rho kinase inhibitors. It helps outflow, doesn't really have systemic side effects, and I think it's being researched for stroke and cancer treatments. Well, as I mentioned, in the United States, medicine is first line, but if you lived in the UK, surgery, glaucoma is considered a surgery problem. We're able to use lasers to apply it to trabecular meshwork to help outflow. And we also have lasers to treat aqueous production, both applied externally as well as internally. As you can see, this is usually done with cataract surgery, endoscopic cyclophotocoagulation. And some of the new exciting things in glaucoma is called micro-invasive glaucoma surgery. This big thing here is just a millimeter. And with our instruments here, we're able to actually insert this 1 millimeter cannula into trabecular meshwork to help outflow and reduce pressure. And this can be done with cataract surgery or on its own. We also have special sutures that you can actually cannulate behind trabecular meshwork and unroof it to help outflow and also reduce pressure. But in a really bad glaucoma, we just need to bypass the whole system, your eye's whole system, to get the pressure really low. And this stent here is about 6 millimeters in length, and the lumen is 45 microns. And we use a needle, just like the needle for vaccinations, to insert it into the anterior chamber. And you can see here when I pull out the needle, aqueous comes out. We close up conjunctiva. Next day, you can see the tube in the eye going outside of the eye and draining under conjunctiva. This is filtering surgery, the gold standard for bad glaucoma. That's it. Thank you. Next, Dr. Carl will be speaking about neuro ophthalmology.
Hi, I'm Ann Gao. I practice neuro-ophthalmology and oculoplastics. How many of you have heard of neuro-ophthalmology? Excellent. So this deals with visual pathways involving the eye and the brain. It's a pretty complex field, but to just break it down as simply as possible, we have afferent and efferent visual systems. Afferent is vision that travels from the eye to the brain, and efferent are ocular motor pathways that travel from the brain to the eye. On a daily basis, everything we do, we're processing vision, moving our eyes, making slow movements, saccadic movements, in order to just process the world around us. Ways that we assess the afferent visual system include visual acuity, which we've talked about the Snellen chart, reading the letters, But there are other measures of vision as well. So visual fields, which we've talked a little bit about with respect to glaucoma, assessing peripheral vision, color vision, contrast sensitivity, and the pupil exam as well is important. In assessing the efferent visual system, we can assess eye movements, smooth pursuits, saccadic jumps in our eye movements, nystagmus. And so, like the sample lady at Costco who was nice enough to let me take this photo of her, my goal is just to give you a couple cases that illustrate patients that might come into the neuro-ophthalmology office. So the first case is a 62-year-old man who complained of decreased vision in his left eye for a year after falling 6 feet off of a ladder. He was referred from the retina specialist who noted that he had no retinal pathology. He just said that his vision was blurry, but when I asked him to sort of expand on that a little bit, he thought that his vision was worse temporally than nasally. We break up a lot of things temporally and nasally with eyes. He had no eye pain, but maybe some pain in the back of his head when he coughed, and he had no double vision. So his best corrected visual acuity, which we also talked about earlier, we want to know what their best vision is with correction. In the right eye was 20/20, and in the left eye, as sort of fitting with his complaint, it was 20/60. He had a 1+ relative afferent pupillary defect in the left eye. His pupils were equal in light and dark, and I just want to take a moment to emphasize that there's a big difference between assessing for an afferent pupillary defect, which gives us information about cranial nerve 2, or the optic nerve, and anisocoria, or looking at the difference in size between pupils, which gives us information about parasympathetic and sympathetic pathways. And we could do a whole lecture on pupils, and I'm not going to get into that, but note that there's a difference, and that this has shown that he has some deficit in his optic nerve on the left. His color vision is also decreased in the left. There's a book of color plates, and he got only 5 of them correct out of 12 in the left eye. He also missed a couple in the right eye, which kind of raised the question, is there some problem going on in the right eye? And this is also supporting a problem with the optic nerve. He had some mild cataract. No matter what level of cataract you have, it's not going to give you an afferent pupillary defect. But on his examination, his optic nerves looked pretty normal. There was no edema and no pallor. So the next thing was to do a visual field test. And there's a lot of information on here. But if we just look at the grayscale images, dark is what we don't see. And on the left eye, in his temporal field of vision, as he told us, he's missing vision. But also in the right eye, in his temporal field of vision, there's some vision loss. And so we call this a bitemporal hemianopsia. Half of the visual field is missing in the temporal field on both sides. So visual field defects can point to specific parts of the brain in terms of the pattern that we see on the visual field. And so vision from the temporal field on the left eye falls on the nasal retina. Those fibers go down the optic nerve to the chiasm where they cross to the other side of the brain. Similarly, temporal vision, light that's coming in from the temporal field on the right eye falls on the nasal retina. And those fibers cross through the chiasm to the other part of the brain. So a patient with a bitemporal field loss points to a deficit in the optic chiasm. So next step, an MRI scan, which shows a pituitary tumor that's compressing his optic chiasm and causing the visual symptoms that he's having. So this is a patient with a benign brain tumor, but in a very bad place, causing problems. He underwent surgery, and much of his vision recovered. The next case is a patient who's 60 years old with diabetes and hypertension, and he came in complaining that he was cross-eyed and had a headache. And so he endorsed binocular oblique diplopia. So in double vision, it's important to assess if the patient is seeing double vision with only one eye open, which can happen, versus if the double vision goes away when they close either eye, which indicates that it's a problem with misalignment in the eyes. And then assessing the nature of the double vision. Is it horizontal? Is it vertical? Or are the two images a little bit of both, which I call oblique? And he also did not have a droopy eyelid, which will be important, and I'll show you why. So there are 6 muscles that move the eye. And of those 6 muscles, the one that moves the eye out is controlled by just one nerve, the 6th cranial nerve. Oh, this didn't light up. But another one that moves the eye down and in is controlled by just one nerve, the fourth cranial nerve. And the remaining four are controlled by the third cranial nerve. So what this shows is that in the patient's right eye, he had deficits in these directions of gaze. He was normal here. And this shows deficits in the eye muscles that are controlled by the third cranial nerve. The third cranial nerve also controls the levator palpebrae superioris muscle that elevates the eyelid, but he didn't have any ptosis. And he also had normal pupils, which is important because parasympathetics travel alongside with the third cranial nerve. So he was diagnosed with a partial third nerve palsy that in his case was due to ischemia from long-standing diabetes and hypertension. And most of these cases, these patients improve over the course of a few months without doing anything. It's really important to distinguish from a complete cranial nerve 3 palsy, which has ptosis and a dilated pupil, because that can be due to an aneurysm, which is life-threatening. So neuro-ophthalmology includes diseases that involve the eye and the brain, and one thing I really like about this specialty is that I work with a lot of other specialists in caring for these patients and treating their problems. That's it. Any questions? So next up is Dr. Rupa Wong to talk about pediatric ophthalmology.
Hi everyone, I'm Rupa Wong. I'm a pediatric ophthalmologist in private practice with the fellow you heard talking about cornea. So that's our daughter, that's our youngest, and I'm going to be talking just mainly about the basics of the eye exam. We're not going to be diving super deep because it's 8 minutes, so I know you don't have a lot of time and I don't want to flood you with information. But these are the things that we're going to be discussing because I think it's really important, even if you go into general peds, even if you just have kids, you're going to want to know these things. So things are different for kids than they are for adults, obviously. And the biggest difference is usually you have to really depend a lot on your examination of a child as opposed to sometimes history. So these are questions that I ask a parent. Does your child seem to see well? Do they squint? Do they tilt their head? Do they hold objects close to their face? Do their eyes appear straight or do they seem to cross? These are all things that are going to help you decide if there's something else going on. So external inspection, again, my daughter when she was a baby, my son. What do you guys notice here? Do you see anything? They're cute. They're cute, thank you, I appreciate that. They're not just crying, they actually have increased tears in both eyes. Does that give you a little bit of a clue? Okay. This is what's called a blocked tear duct or congenital nasolacrimal duct obstruction. Tends to be familial. My husband's family, they all have it in their side. All 3 of my children had it, all on the same eye actually too. 95% of the time, this is going to go away with just some simple Kreigler massage to the nasolacrimal system. You can find my YouTube video. It's a 4-minute video where I'm demonstrating how to do it on my son, and I'll show you the little video too. But 5% of the time, we have them taken to the operating room. We only do that once they're past 1 year of age because there's so much spontaneous resolution. So that's something that you should be aware of because it's really quite common. Oops. Okay, I don't have the. So there's the, I think they said there's a little bit of a delay. It's important to know just the proper technique of this. I do see a lot of people rolling their finger around in the inner campus. That's not how to do it. I don't know if this video is going to play or not. There it is. There it goes. And he's trying to eat my hand. That's my second son, the middle one. You want to recommend lacrimal sac massage twice a day. And sometimes you might do antibiotics if there is tearing and discharge. Very rarely do we need to intervene surgically. This one's an important one, the red reflex test. I bet if you guys have gone on your pediatrics rotation, you have learned this already. You need to make sure you dim the lights. It's really not worth it to do a red reflex test in this kind of lighting. You can use your direct ophthalmoscope. You need to be about 1 to 2 feet away and make sure to set the dial on 0. Illuminate both eyes simultaneously, and what you're trying to assess is to compare the red reflexes for symmetry. So when you are also using the direct ophthalmoscope, it's a really nice way to be able to tell if there's any kind of strabismus or misalignment of the eyes. And you're going to look at the light reflex on both eyes, and you can see how, I think they said this, exotropia. You see how the light is not centered? and hyper, as well as ESO. So this is going to give you a quick and dirty way to be able to tell without doing all the things that I do in the office. When you do things like this, you could see here from the red reflex how off-center her eye is. She had esotropia. She was a little farsighted. I tried glasses first, and then we operated. I operated on her. I did her back in Boston about 16, 17 years ago. Now she texts me through Instagram. It's really crazy. That's the awesome part about pediatrics. This is what we do. I'm not really going to go into it. This is how we quantify in the office, pediatric ophthalmology, if it's an eye crossing in, wandering out, or vertically misaligned. Middle sun again. I use them because they're free. I don't have to pay them other than in screen time or candy. Watch his eyes. Okay, you see that? So this is actually quite common in nearsighted individuals. I'm assuming some of you are nearsighted. More than likely, you all have some kind of intermittent exotropia as well. This is really common. You don't have to do anything for it. If the 3D vision is good, if the visual acuity is good, and the control is good. Only when I disrupt his fusion do you see the eye wandering out. Sometimes when he's looking out at the sun, this is why in England they call it squint, because kids will squint one eye to avoid double vision. These are all things that you want to pay attention to. External exam, that's why it's important. Extraocular motility, I always use a toy to check for the movement of the eyes. I know you guys are used to writing EOM intact. It's not the most helpful, but it's good. It gets the job done. You want to always have the parents hold the child's head because the child is going to try to move all around. This is my technician. Take a look at her eye movements. And again, you're just trying to figure out, is there something abnormal? Okay, this is called Duane syndrome. It is when you have a abnormal innervation of the nerves to the muscles. So it's causing, if you want to see it one more time, watch as she looks with the left eye in. You'll see that the eyelid fissures are narrowing, which is one of the hallmarks of Duane syndrome too. So this is type 1. Vision in infants is hard. Everybody else, all my colleagues, they can check 20/20. I can't a lot of times. I can sometimes. But a lot of times what I have to do is put a patch on the eye and see if there's a difference. This kid really had a difference in vision in the right eye. He did not like the patch over his left eye, indicating that the vision was compromised on the right eye. Visual development. You want to just know your hallmarks as terms of when you start to notice the eyes should be aligned. Eyes don't just cross in normally. A little bit of eye crossing is normal around up until age 3 months, until they really start to gain their muscular control. But it's our vital sign, and it's a skill, and you always want to do one eye at a time. You can use eye charts for pre-literate kids. We don't love this one, which is in a lot of pediatricians' office. That's called the Allen cards. Why do we not like it? Because you can guess. Obviously, that's a birthday cake. Even here, you guys in the back row might be able to guess just based on the shape. We prefer this, hopefully. This is better, HOTB, all right, because everything blurs a little bit more consistently, and there's another one called Neal symbols. This is the one I use in my office primarily for kids that are not literate. I have them match. Pupils, we'll just go through this. You guys already probably got that from the neuro-ophthalmologist, so I'm gonna speed through that right there. And then I just want to really quickly talk about amblyopia, because it's quite common. 3 to 4% of children have amblyopia. Typically, usually, patching was the mainstay of treatment, though we've got some new options now. There's 3 types of amblyopia. Refractive. Refractive is just like what it sounds. When the glasses prescription is unequal between both eyes. That means the worse seeing eye, the brain doesn't like to see out of that eye, right? It's gonna prefer to see out of the better seeing eye. It shuts the eye off that's not seeing as well. Because of that, we have to force the brain to use the worse seeing eye by patching the better seeing eye. I always talk about it as like eye exercises. You're strengthening the muscles of the eye when I'm explaining it to a child. Another cause is strabismus. So if the eye is misaligned, and this is not always, sometimes it can cause a decrease in vision. And the reason for that is you're not utilizing the proper part of the retina to see well. It's not fine vision. Another reason to get amblyopia, and it causes then this vicious cycle. The decrease in vision might cause the eye to turn in more. But strabismus does not always mean bad vision. This is a child I operated on. She has perfect 20/20 vision in each eye. So it's not always the case. Deprivational amblyopia, that means just like what it sounds, something is depriving the eye for vision. In this case, it's a droopy eyelid. Sometimes it can be a cataract. And when you remove those things, it can improve the vision, but you still got a patch. So when I do cataract surgery on a kid, I tell the parents that my job is the easy part, their job is the hard part, because now, especially if it's a cataract in one eye, you're gonna have to patch, and kids hate wearing a patch. Patching is the mainstay. Anywhere from about 2 to 4 hours is now the recommended amount of time, and then I see them every 3 months. You can also use atropine. It's a dilating drop. It'll dilate the pupil for about a week, but the dilation effect in terms of paralyzing the focusing muscle. So it kind of does the same thing as patching. It blurs the vision in one eye. But here's something new. This is a new FDA-approved device. I do speak for them and consult for them, but it's the first FDA-approved binocular treatment for amblyopia. And it's basically a VR headset that then kind of uses these grayed out zones to patch the eye. So clearly kids are gonna prefer to watch 700 hours of whatever versus wearing a patch. So this is kind of exciting that we have this now. And I know I'm probably over time, so I'm gonna skip the cases. Or if I have, you tell me. I can do one? Okay. So this one, this is a good one. This is an important one. This will be on your boards. They always want to make sure you're not going to kill a child. This is the one to know. White pupil, right eye. 6-month-old girl with a white pupil, noted on iPhone pictures. Blinks to the light bilaterally, and she's fussy when the eye is covered. Okay? You see Bruckner test, right? So clearly an asymmetric red reflex. When to refer immediately. Here's the list of all the things that it could be. Congenital cataract, retinoblastoma, that's the one we're worried about. Retinal detachments, there's hemorrhage. Once blood starts to get older, it can look more white or yellow. Infections, there's all sorts of congenital conditions. But the one they always want to make sure you don't miss ever, ever, ever is that one right there. But in this case, it was a congenital cataract. And that's just a pacification of the crystalline lens. Some people are surprised to know that babies can have it. This was, again, another baby I operated on probably about 16 or 17 years ago back in Boston. He was a triplet, if you can imagine. That mom had triplets, and he was the small one. And also the only one with a cataract. It can cause permanent visual loss secondary to deprivational amblyopia. But here, another case from my Boston days is the thing we're worried about. And here you can really tell if you look, it's a picture I took. I mean, clearly he's in the operating room, so I took this photograph right before we did his surgery. You can see those blood vessels, right? And that's retinoblastoma. That's what it looks like when you might catch a glimpse. It's really hard to miss this. You'll see it even with your direct. And in the old days, we used to always do, I say old days, we used to do CTs. There's now possible increased risk of tertiary cancer, so we don't really do that, but we would do it because you can see the calcium. And that's the treatment. So enucleation, external beam, radiotherapy, chemo reduction. Now there's a lot of stuff with brachytherapy and even doing seed biopsies. It's a lot of really interesting research going on, but this is something you don't want to miss, and you do want to always know. They love to ask about these related cancers on board exams too. And check the siblings. Always check the siblings. Not all of them are going to be germline mutations, but you don't want to miss it. You should be assessing for red reflex in every well baby exam. Close that. All right.
Hi everybody, my name is Neal Atebara. I'm originally from the Big Island. You might have heard of Atebara potato chips, but now I am a retina surgeon at Queens, and right now we're going to talk about the retina. So the retina lies in the back of a very dark and cavernous eyeball, so you can only see it with very specialized instruments. Okay, so the optic nerve is a cable that connects the eyeball to the brain. The macula is the center part of vision. The artery and vein feed oxygen to the retina. The left and the right retinae are mirror images of each other. So you're all familiar with the direct ophthalmoscope. The good thing about this is that it gives you a high magnification, and so it's very good at seeing the optic disc. But the narrow field of view makes it very difficult to see the periphery, and that's where retinal tears are, and that's where retinal attachments start from. So that's why you see most ophthalmologists actually have what's called the indirect ophthalmoscope, the thing that we put on our head. It gives a nice wide view, which makes it easier to see retinal tears in the periphery and see retinal attachments. Unfortunately, there's a steep learning curve to this. To see the front part of the eye, it's essential that we use this big honking microscope called the slit lamp, and we get a nice binocular view of the front of the eye. With a special lens, we can actually see the back of the eye too, but unfortunately that has a steep learning curve as well. An optical coherence tomography, or OCT, is a very valuable instrument that we use. It gives us a three-dimensional scan of the retina in high resolution. Diabetic retinopathy is the most common cause of blindness in the younger population, people younger than 50. What you see is scattered microaneurysms throughout the retina in both eyes. All people with diabetes should get a retinal evaluation at least once a year. What happens is the high blood sugar over time, over years, causes slow damage to the capillaries, and that causes retinal ischemia. The ischemic retinal cells release vascular endothelial growth factor, or VEGF, and that leads to growth of abnormal blood vessels, which can bleed, and if untreated, turn into scar tissue that can literally pull the retina off the back wall of the eye that causes permanent loss of vision. VEGF also causes swelling of the retina called diabetic macular edema. So what we do is we do an injection into the eye with a special medication that binds to and blocks vascular endothelial growth factor, and that causes regression of the edema. The downside of the injections is that it doesn't last forever. It lasts about 1 to 4 months, and then we have to repeat the injections frequently. Laser treatment is used to more permanently decrease VEGF production, and that's what we use for neovascularization of the retina. Age-related macular degeneration is the most common cause of blindness in the older population, people older than 50. What you see is little yellow dots in the macula, which are called drusen. On cross-section, these appear as bumps, and the bumps represent weak areas in the RPE. What happens is abnormal blood vessels can grow through the worn-out areas and start to leak fluid or bleed underneath the retina, and that causes permanent loss of central vision. So this is what patients see. The center part of the vision can become obscured, or it can be just missing. A modest amount of reduction in progression of macular degeneration can be treated with antioxidant vitamins. Vitamin C, vitamin E, lutein, xanthine, and zinc can help slow the progression of macular degeneration. More acute treatment is, again, with the anti-VEGF injections, which is quite effective in stabilizing macular degeneration. But again, it has to be repeated every 1 to 4 months. You often hear patients ask about flashes and floaters, so let's talk about that a little bit. The inside of the eye is not empty. There's actually a clear, sticky gel called vitreous. As we get older, for everybody, at some point, the gel will contract and pull away from the back part of the eye. When this happens, the back surface of the gel is not totally flat. Where it was stuck to the retina, you see the outlines of blood vessels, and those cast shadows on the back of the eye. So those are the floaters that patients see. They'll describe it as squiggly lines or spider webs. And in and of itself, the floaters don't cause any damage. But if the gel tugs on the retina, it can cause flashing lights. We call them photopsia because the retina is stimulated, and that's how the brain interprets the tugging. If it tugs too hard, that's when there's a trouble. You can get a retinal tear. If we catch it early enough, then we can simply do laser treatment in the office. But if we do not treat it early enough, then fluid can go through the tear, which can then dissect the retina off the back wall of the eye. That's called a retinal attachment, and it can lead to permanent loss of vision if it's not treated early enough. So this is what a retinal attachment looks like to the patient. You see a dark shadow coming from the periphery from any direction and encroaches upon the center part of the vision. If it goes through the center part of the vision, then we've kind of lost the reading vision. It's already going to be permanently damaged to some extent, so we try to catch it before it gets into the macula. What patients see is actually upside down from the reality within the retina. So an infratemporal retinal attachment corresponds with a supranasal visual field defect. So this is how we treat retinal attachments. One treatment is to do a surgery, where we call it a vitrectomy. We take out the vitreous gel that caused the retinal tear. We then put laser treatment around the retinal tear to spot weld it in place, and then we put a gas bubble inside the eye. The gas bubble plugs the tear so fluid can't go back in and redetach the retina. Now bubbles rise, so the gas bubble will only fill the top half of the retina. And if the tear is in the upper half, that's fine. But if the retinal tear is in the bottom half of the retina, then what we do is we put the patient on their side, and that covers the hole and keeps the retina attached. Another thing we do is a buckle. Sometimes tears want to stay open. A buckle actually pushes the eye, it indents the eye a little bit, and that helps the tear stay closed. What if the tear or the hole is in the macula? Well, we do the same thing. We do a surgery to take out the vitreous gel, we put the gas bubble in, but in order to make the bubble close the hole, we have to put the patient in the face down position for 10 days. Strokes are when you get a blockage of a blood vessel in the brain. The retina is very similar to the brain, so when you get a blockage, we call it a retinal vascular occlusion. If the main vein that drains blood from the retina is blocked, we call that a central retinal vein occlusion. We see these huge hemorrhages in all four quadrants. If only one vein is blocked, we call it a branch retinal vein occlusion. The main causes of this is diabetes and hypertension, so make sure that the patient is worked up for that. If you get a blockage of the main artery that feeds oxygen to the retina, it's called a central retinal artery occlusion. Sometimes we can see the embolus and something called a cherry red spot. That's when the whole retina is whitish, except for the macula, and that looks like a cherry. Sometimes we see an embolus in the branch, and that causes whitening only within the distribution of that branch. Artery occlusions are a risk for stroke. So what we do is we do a workup to look for the source of the embolus. So we do a carotid ultrasound and a cardiac ultrasound to look for an embolic source. So if we're, okay, do we have 15 seconds? Okay, so this is a typical surgery that we do, but it's not a typical case. I was asked to do something, to present something gross, so I'm trying to oblige. We have a 60-year-old man who unfortunately drank contaminated water with Taenia solium eggs. What happened was the egg turned into a larva which burrowed through his gastrointestinal system, and then what it does, it wanders through the connective tissue of the eye. It just happened to randomly go to the eyeball and turn into a cyst and grow under the retina. So this is the one. The patient actually literally came and said, "Doctor, there's something moving in my eye." Usually I don't believe that. So in surgery, I cut through the retina and pulled out the cyst. The trouble is that if you pop the cyst or you don't get the thing out, it'll cause an inflammatory reaction that destroys the eye. So it had to come out intact. Unfortunately, it did. So the patient did fine. And that's all. Thank you.
All right, good afternoon, everyone. We saved the best for last. I'm Dr. Vivien Tham, and we're going to be talking about uveitis and the inflammatory diseases of the eye. So you might want to ask, what is uveitis? And actually all it means is inflammation inside the eye. Specifically, it affects one or more layer of the three parts of the eye that make up the uveal tract, or the pigmented part of the eye. And this includes the iris in the front, the ciliary body in the middle, and the choroid in the back. So uveitis is important because it's the third leading cause of blindness in developed countries, and it tends to affect people in the prime working ages. There are, uveitis can be distinguished into 4 different types. Anterior uveitis is when you have inflammation of the front of the eye. That's also known as iritis, and that's the most common form of uveitis. When it affects the ciliary body, it is known as intermediate uveitis, and it tends to affect younger people. When it affects the posterior part of the eye, or the choroid, it can cause a lot more vision loss. And when it affects all layers of the eye, it's called panuveitis. It can be also categorized chronologically, with acute uveitis being an immediate inflammatory episode, and you have a one-off inflammation. Recurrence is when there can be more than one episodes, and chronic is when it just keeps on going and it doesn't stop. One other type of categorization is non-granulomatous and granulomatous, and that is determined by the number and the amount and the type of white blood cells that are floating inside the eye. In this example, you see the big white spots. Those are granulomatous deposits. So in general, there are 3 main causes of uveitis, of which we can categorize them into infectious, autoimmune, or idiopathic. Inside the infectious category, the most common causes are the herpes simplex, herpes family-related viruses, including herpes simplex, herpes zoster, cytomegalovirus. Okay? Toxoplasmosis can also cause uveitis. Much less common is TB and syphilis, but probably the most important to note for any doctor to know, because TB and syphilis can masquerade as any type of uveitis. And less commonly, you can have Lyme and cat scratch, infectious cause. Autoimmune is a very big category, of which HLA-B27 diseases, that includes the inflammatory bowel disease, ankylosing spondylitis, and psoriasis is a big category. Rheumatoid arthritis, just because so many people have rheumatoid arthritis. Lupus and Wegener's can all cause uveitis. Sarcoidosis and multiple sclerosis sarcoidosis is a little bit more common. Multiple sclerosis, and then more rare, these conditions called Behçet's and VKH. Of the idiopathic type, that's the most common, and all idiopathic means that we don't really know what the cause is. We don't have enough medical information or knowledge right now, and as time goes on, we'll be able to categorize these cases more. Symptoms of uveitis is typically presented with a red eye, and usually with or without pain, usually no discharge. There's usually blurry vision associated, but the vision can be normal, especially at the beginning of the disease. Most commonly, people complain about photophobia, or light sensitivity to bright lights. They may also complain about floaters, and these are little black specks floating in the vision. I'd like to illustrate this with a case history. This is a 68-year-old female who presented with a 2-month history of redness, boring, painful pressure. As you can see, both eyes are extremely red. She gives a history of ocular rosacea for several years, and that's when people have inflammation of the eyelids and around the eyes, and also a history of allergies, and has had allergy shots for many years. However, after treatment for allergies, dry eyes, ocular rosacea, and they were all not effective, this patient was referred to me, and she did not have any change in vision. However, if you notice on the picture, there's some very dilated, deeper vessels and this violaceous hue to the inflammation. So on the differential diagnosis, we have chronic conjunctivitis, allergic conjunctivitis, dry eye disease, ocular rosacea, episcleritis, anterior uveitis, and scleritis. So because of the pain and all the deeply dilated vessels, this actually is anterior scleritis. So from the history, you can try to elicit to see if there's any associated systemic autoimmune diseases like rheumatoid arthritis, Wegener's, lupus, polyarteritis nodosa. If there was a history of previous surgeries, especially pterygium surgery with mitomycin C or beta irradiation, if there are a history of multiple surgeries in ocular surgeries in the eye, previous inflammatory episodes, or even a history of trauma can cause scleritis. So uveitis specialists are the most cool of the ophthalmologists because we're the only one that actually order tests and diagnostic tests. I don't think any other ophthalmologists do that. We will actually, in this type of situation, do a complete blood count, ESR and C-reactive protein to look for inflammatory state, serum autoantibody screens, including anti-nuclear antibodies, anti-DNA antibodies, rheumatoid factor, anti-neutrophil cytoplasmic antibodies, actually do urinalysis to look for nephritis. And most importantly, although we always do it, and it's very rare that this comes back positive, you want to not miss the syphilis and the TB cases that are out there. And I found both types of these cases presenting as uveitis. And it's life-saving when you find that diagnosis. Serum uric acid for gout and the sarcoidosis screen. So with this patient, actually her workup was negative and she was placed on 80 milligrams of oral prednisone. And as you can see, the eye, inflammation in the eye came down right away with high-dose oral prednisone. However, with oral prednisone, this is not something that you can keep on for a long time. And so that prednisone was tapered pretty quickly, and the inflammation started to come back, and she needed an immunomodulatory drug to help decrease the inflammation, and mycophenolate was started, and she did well on this. So a few words about anterior scleritis. It is the most common form of scleritis, and it can be categorized into the diffuse form, the nodular form, or the necrotizing form. In the diffuse form, there is anterior scleroedema present, and usually dilation of the deep episcleral vessels. And in the clinical case we show, that was a diffuse form of anterior scleritis. In nodular disease, there's actual distinct nodules of scleroedema present. They can be single or multiple nodules, and they are tended to palpation. Necrotizing form is the most severe form of scleritis. There's severe pain and extreme scleral tenderness. There's associated infarction and necrosis of the sclera with possible exposure of the choroid. There's also a rare form called scleromalacia perforans. Notably, there's a white and thin avascular sclera with both choroidal exposure and staphyloма formation. As we mentioned before, many connective tissue disorders are associated with scleritis and other inflammatory diseases of the eye. So this is my last slide, a high-yield takeaway slide of the autoimmune conditions that are associated with scleritis. Rheumatoid arthritis is the most common, but don't forget there can be infectious or surgically or trauma-induced causes. Most commonly, oral nonsteroidals are the first line of treatment for mild to moderate scleritis. However, corticosteroids are usually needed. Topical corticosteroids don't usually work, and high-dose systemic corticosteroids are usually required. Don't forget to go on to the immunomodulatory drugs as the next line. And quite often we engage the help of our rheumatology colleagues with this. And these include methotrexate, cyclophosphamide, mycophenolate, cyclosporin, azathioprine, and more recently there has been tumor necrosis factor alpha inhibitors, infliximab and adalimumab. And those have all been very effective in treating inflammatory diseases of the eye. So I'd like to conclude to say that uveitis is cool because we don't just save the eyeball, we save lives here. Thank you very much for your attention.
So I'd like to thank all the speakers. A fantastic job. We've only been doing this for about 3 years, and I really mean this. I think this was the best series of lectures that we've ever had. Our goal is to expose you to ophthalmology. Many of us trained at big eye centers where the eye institutes are almost as big as a hospital. And unfortunately, you don't get that same kind of feel here, but many of us have trained there, so we can at least give you a little bit of insight into all of the subspecialties of ophthalmology. And there may be a few of you who would be interested in ophthalmology, so this is our one chance to educate you. And as you can see, many systemic diseases are related to what we do in ophthalmology. There's so many now, and so many treatments that we also have to coordinate with rheumatology or with other specialties. I'm sorry that we had to rush through the lectures. I would like to open up some to questions. If any of you have questions, we usually do a very interactive discussion, but because we're videoing this time, we couldn't do that. But any questions? We do have a lot of the specialists here still. Any questions that anybody has? Oh, go ahead.
How do you suture a cornea?
How do you suture a cornea? Did we lose Jeff? It's very, very tiny sutures, and I know Dave Waters teaches a lot of the suturing courses, but it's very fine sutures. A laceration, it's often interrupted. You can do continuous sutures, but it's very small. The one thing I would say is it's all under the microscope. And of course, the patient doesn't feel it when you're doing it. But any other questions? Yeah. Mm-hmm.
I heard one of the speakers talk about how you can have glaucoma without increasing the droplet pressure. And I was wondering how that's, because my impression is that glaucoma, the condition is increasing droplet pressure. So I was curious.
Yeah. Troy, why don't you come up? Oh, can you talk loud enough?
Yeah. There's a lot we don't know about glaucoma. As I mentioned, it's a neuropathy of the optic nerve. But pressure is the only thing we can change to protect the optic nerve. And when I was in school on the mainland, 90% of patients had high pressure. Little did I know coming home, 90% of glaucoma in Japanese is low pressure glaucoma or normal pressure. So there's something in the brain, that's not going well, and the optic nerve is deteriorating. It could be vascular, could be some neurotropic factor in the brain that we don't know, but Japanese population here big, and 90+% have normal pressure glaucoma, so we don't understand everything.
Okay, any other questions? So I know that there are probably questions, but it was kind of difficult to ask the questions in this big audience. So one of the most important parts of the next part is you're going to be in small groups, 15 minutes for each case, and there'll be somebody there that can answer questions in all the different areas. So hopefully any question that you have that you've been presented with, you can ask it there. We're going to start right after, so just go over, there's going to be the 6 outside small rooms. There's going to be a physician in each room, and you can discuss it from there.